I don't need the mic, I think. Yeah, there's mics all over the room.
Cool.
Okay. So today's presentation is being recorded and will be offered on demand for those unable to attend in person. This activity is being accredited through a joint providership with CME Consultants. If you are attending in person, please sign in on the sign-in sheet, and this sign-in sheet will be sent to CME Consultants to verify in-person attendance. A CME evaluation form and post-test were included in the email containing the link for this presentation. Everyone who would like to receive a CME certificate must complete the evaluation form and submit it to CME Consultants to receive CME credit. If you are watching the recorded presentation, you must also submit and pass the post-test. The planners and faculty for this presentation have nothing to disclose, and there is no commercial support for this activity. And just a reminder, there are microphones throughout the room, and they do pick up side conversations. Thank you.
Can everyone hear me all right? Wonderful. Thank you for taking time out of your busy day. My name is Daniel Orlovich. We'll be talking about what's new in pain medicine, tailoring this towards what you guys can use. So pain management, this is what a lot of people think of when they hear the words pain management. And to be frank, 4 years ago, this is what I thought of as well. Someone very dark, looking at the clock constantly. When can I take my next pill? I can't sleep. Mood very depressed. Life is not going to get better. I'm here today to say there are new ways we can change that paradigm. Why am I here? I was a pharmacist with the FDA in 2009, so we're still going up on the opioid crisis. I'm not going to belabor this point. It's been in the news enough. I also practiced as a pharmacist at the peak of the opioid crisis. So we hit that around 2010, 2011. So how do we get that curve going down? How do we continue that trend and still get patients out of pain? Since this is a CME event, we got to talk about some cultural issues. So a lot of primary care physicians in the United States here believe that opioids are overprescribed. However, in Japan, only 6% of patients or primary care physicians feel that opioids are overused. So culturally, we see a lot more prescribing of opioids. And I'm sure if Chip is dialed in and people in the hospital say, look, this outpatient stuff does not concern me really. What about when we're inpatient? We see 2 times higher hospital costs to those who abuse opioids as opposed to those who do not. So there's a tremendous financial burden as well. Let's talk about how pain was and where we're trying to get to. How it was opioids, opioids, opioids. Now the buzzword is multimodal agents. We're talking about minimizing opioids, reserving them for patients with cancer pain as well. Before, anybody who took a needle can do epidurals, and that was it. Now there's stringent requirements, board certifications, fellowship training as well. Before, a lot of it was epidurals, epidurals, epidurals. Now we're doing really advanced things. We'll talk about them here. Spinal cord stimulators, interspinous spacer devices, basovertebral nerve ablations, peripheral nerve stimulators. So lots of new toys that give patients relief. Okay, really quickly, so this is a photo. I like to start with a story. This is a photo that's my brother on the left, my wife in the middle, my father on the right. This is in France. And why I'm inspired and passionate about this stuff is my father, when we lived outside of Chicago, in a suburb there, he was just walking our dog. He slipped off the curb and kind of rolled his ankle. He developed complex regional pain syndrome. None of his primary care physicians knew about this. The pain physicians there weren't really promoting it as well. So when we go and take vacations here, he's kind of lagging behind because he's got pain that's permanent. His mood is forever changed. What happens if someone would have offered him this therapy? Could we have walked around France? Could he have been in a better mood? Hopefully I can affect somebody's life out there and make them so they have a much better life. Financial disclosures, the obligatory. I started a test prep company when I was in med school. It was later acquired by UWorld. Then I'm also a contributor and early investor to Thalamus, the schedule interview platform for residents and fellows. About me there, I'm a licensed pharmacist. I come through anesthesiology, board certified in pain medicine. And I am part of the CIN, so that is very important. I know I'm on the nice list. You can circle my name, which is awesome. Thanks to Danielle and Corey for helping out with that. Where am I located? So I am in CME Monday and Wednesday afternoon. I'm also in Porter Ranch, Thousand Oaks, and Van Nuys. I still hold an appointment up at Stanford. And then for those who know Dr. Michael Dorsey, he'll be the next guest on the podcast that I host for the Pacific Spine and Pain Society. My training about me. As I said, I am a pharmacist. I went to med school in UC Irvine, anesthesia residency at Stanford, and then pain fellowship at Cedars. But those are just logos. So what did I learn? At Butler, somebody told me, my mentor said, if you shut up and listen long enough, patients will tell you what's wrong with them. What does this have to do? If something's not indicated, if you're not treating the right pain, you're going to be going on the wrong path. At UC Irvine, Dr. Nguyen told me, no one cares how much you know until they know how much you care. So that's very important. At Stanford, Dr. Barrett Larson said, make tomorrow happen today. So it is my responsibility to be a good steward of these products. Next, Dr. Howard Rosner said, you're a specialist. Do special things, meaning go to a community, help them out, understand your ecosystem. Don't do epidurals if a million people are doing epidurals. How can you contribute and add something new to the community? How can you work with them? The objectives for you. So we're going to identify patients who may benefit from these interventional advancements. 2, we're going to understand them broadly, so you kind of explain them. And 3, most importantly, we'll talk about the CDC recommendations, being in compliance with them. So the whole talk today is basically about 4 big advancements. We're going to talk about 4 therapies in particular that really have moved the needle in pain management. What are the advancements? Benefits of these? They're all minimally invasive. So the biggest incision is going to be about that big, that's it. No one is staying in the hospital, everyone's going home, sleeping in their own bed. Gets patients moving, it gets them off opioids as well. These are the big 4. The first one is an ablation of the nerve in the vertebrae. Second one is an interspinous spacer. Third is the ablation of the hip, knee, and shoulder. And the 4th is a spinal cord stimulator. Speaking of these things, especially the spinal cord stimulator, I want to bring up a quote. Because some people, I understand, might be skeptical of these therapies, and rightfully so. And there's this quote in Taoism that says, when the wrong man uses the right means work in the wrong way. What does that mean? It means a few years ago, even now today, a lot of people are using those 4 therapies in incorrect patients. And then people say, hey, that therapy doesn't work. I'm arguing, hey, no, you just picked the wrong patient. Another example, proper patient selection is key. When you go out and you order a steak, when the waiter asks you what you want to drink, you don't say a Coke, right? You're not pairing it correctly. If you have steak or fish, you should probably get wine, red or white, right? If you're going for a brat or a hot dog, you should get a Coke, that's fine. What I'm trying to say is these therapies, you need to match them and pair them correctly in order to maximize their efficacy. Let's start with the first case. This is a 40-year-old gentleman, 20-year history of lower back pain. It's dull and achy, doesn't radiate, it kind of stays back there. Sitting in the car definitely makes it worse, especially when he goes to the west side for work. He's gone a few epidurals, none of them seem to work. He doesn't want another epidural, he says. He's extremely fit, he tries to work out. He's tried anti-inflammatories, CBD cream, physical therapy, muscle relaxants, no relief. Someone gave him tramadol, but he said, look, I didn't like the way it made me feel, it didn't really work. He was told his MRI was unremarkable. What jumps out to me here? He's a young guy, he's 20. Doesn't radiate, it sticks right there in his back. Sitting in the car makes it worse, that's important. He's gotten epidurals, no relief whatsoever. He's tried enough things, and his MRI was unremarkable, but no one actually walked him through it. Let's talk about the first one, the ablation of the nerve in the vertebrae. I say bone is home. Why? Because you see where the needle goes inside the bone. Bone is home, bone is safe. That's where we like to be, it's what we like to touch, it's reassuring. How can you identify patients? Here's how you identify patients. If it's lower back pain that does not radiate, I tell patients it's like the kind of imagine wearing a belt. They always say, it's right here, it's right here. That's axial back pain. It's not that sciatica where it's shooting down their legs. The MRI might show modic changes. This one's tricky because they may call it different things. Degenerative end plate changes, perhaps. Sometimes it's not in their impression, but it's at a different part of the report. And finally, pain worse with sitting in a car. They will tell you, hey, coming here really just caused me a lot of pain. So the ablation of the nerve and the bone, kind of the breakthrough was, if you look at the literature, the breakthrough was there are nerves inside the bone. Those nerves are responsible for a lot of pain. We always thought it was the discs that were herniated. Now we're understanding that the bones can generate some pain as well. I brought up and talked about modic changes. It's named after a physician. recently. The middle picture shows you modic changes. You can see one is bright white, one there's type 1 and type 2. But point being, if you bring it up and show a patient this, they will see it. And finally, how do you do it? You stick a needle through the bone, you heat it up, and deactivate the nerves. What's the evidence? Evidence is pretty convincing in my medical opinion. 2 level 1 randomized controlled trials. Once again, the average age of these patients, they're young, 50. 50% of the patients got 75% relief. A third of them had 100% relief. A third of the patients, 100% relief. I never promise home runs, but in my book, that's a home run. You could see about 70% decrease in opioid requirements. And then the disability score went down twice as much as what we consider clinically significant. And patients always say, Doc, am I going to have this done in 6 months? This is sustained over a 5-6 year period. So this is very encouraging. Case 2, 87-year-old guy, past medical history, multiple myeloma, hypertension, CAD, status post-CABG, AFib and Eliquis, and diabetes. He presents with lower back pain and leg pain. And he describes it as cramping and heavy. He notes that it doesn't really go past his knees, it's always above. He says walking makes it worse, and when he goes to Costco with his wife, he actually likes and enjoys using the cart that makes it better. He's found some relief with Norco, and the MRI showed him stenosis. And his biggest thing is he wants to be active. When he goes to the Dodgers games, he can't walk from the parking lot as well. He used to say, I'd walk all the way in, now I have to stop twice. He does not want surgery. What jumps out to me, this is an elderly gentleman. He is medically complex. He has a lot of conditions there. Walking makes it worse, and it doesn't go past his knees. Bending forward makes him feel better, and he has stenosis. Key word here is stenosis. We'll talk about the second one, that is the interspinous spacer, and that's the doorstop, and we'll talk about why we call it the doorstop. Anytime you go to Costco or Target or Walmart or wherever you go, you will see these people with a shopping cart when you're walking around. How do you identify these patients? 3 things. 1, have you been told that you had stenosis? Is that in the chart? Are you not able to walk as far as you could before? People will tell you, I used to walk all the way to the end of the park, and now I have to stop at this bench and that bench. And finally ask them, do you want spine surgery? Some people are adamant that they do not want spine surgery. Why do we call it the doorstop? So stenosis, as we all know, is a fancy way of saying there's tight spaces. And basically, when they're using that shopping cart, they're opening up those tight spaces. So this little doorstop makes it so their spine is opened up and they don't have to bend forward. Why is it a doorstop? You see on the right, you stick this little device in, just like a doorstop. You know, there's a point where you can't put it in any farther. So that's what the doorstop will do. And you see how small it is as well. Does it work? 90% of patients are satisfied at 5 years. Biggest thing about this one, you can take it out. You turn right to put it in, turn left to take it out. So it's completely reversible. 75% of patients had improvements in their leg pain that lasted at least 5 years. 85% of patients went down in their opioid requirements. Really quickly, any questions so far? All right, we're making good time. So this was a lady in Simi. I was taking her history, and she says, Doc, have you seen Dope Nation? I was like, oh, what is Dope Nation? I have no clue what Dope Nation is. She's like, look it up, Google it. And I was like, okay. So I pulled up Dope Nation, and it's these 2 guys. And I'm like, what does this have to do with our interaction today? And then it said, suggested Dope Sick. And I was like, oh, did you mean Dope Sick? And she said, oh, yeah, it's that show about the opioid crisis in America. And I said, oh, okay, yes, I know what you're talking about. Well, why did I put this up here? We've been saying opioids usually don't work. There's a high risk of addiction, lots of bad side effects. Now, whoever the producers are, they should win all the awards in the world, because patients are coming in now saying, have you seen Dope Sick? I don't want opioids. I don't want opioids. So a lot of people want to move away from opioids, and this is very encouraging. Case 3. So this is a 57-year-old female. She's got depression, anxiety, fibromyalgia, and breast cancer, as well as chronic left shoulder pain. An orthopedic surgeon saw her and said, you know what, I'm sorry, but you're not a surgical candidate. Now, she comes to you and she has a list of 2 sheets of questions. Her range of motion is limited in the shoulder, and she confides in you she doesn't really like medication, and she wants to swim again. That's all she wants to do is swim again. What jumps out to me? For primary care physicians out there, These are challenging diagnoses, right? Depression, anxiety, fibromyalgia, breast cancer as well. She's been through a lot in life. She is not a surgical candidate. She has a limited range of motion. She doesn't want medications. She is focusing on her functional activity. That's really important. Functionally, she wants to get better. She wants to swim. That's her goal. So how do we do that? We're going to talk about ablation of the shoulder, hips, and knees. People always say, what about the ablation of the back? Everyone knows about that one. These are kind of the newer ones, the hip, shoulder, and knees. I think of, cooking out. People always say, if you're going to burn the nerve, is that going to be an incision? I say, no, they're tiny needles, just like that. That gives enough space to burn. So how do you identify patients? Ask the patient, do you not want surgery? Or have you had it and you're kind of plateauing with physical therapy? Did the cortisone or gel shot not work for you? And did they tell you you're not a surgical candidate, you're too young? So how exactly does it work? Basically, it's radioactive waves, it heats up the nerve, it changes their chemical structure, and that kind of stuns them. It is not permanent, they grow back. That's why it doesn't last forever. People always say, if you're going to burn my nerve, am I still going to be able to move? Yes, you will. This is just basically a purely sensory function. There's going to be no motor impairment. That lady will still lift up her shoulder to swim. Where can we do it? Everyone thinks this is a really complex procedure. It's not. If you look at an x-ray, you can see where we're putting these needles. So we do it once again for the shoulder, hip, and knee. The relief can last 6 to 24 months. So people who say, I don't want surgery just yet, I want to go on a trip, I want to strengthen, we can give them relief. Does it work? Does it work? So people always say, but this is like the gel, or this is like the steroid injection. So if you look at, compared to injections like those for the knee, it's 4.5 times more likely to have relief at 6 months. The number needed to treat for knee pain, 2 patients. So I'm sure everyone sees 2 patients a week who have knee pain. If you do this in 2 of the patients, at least 1 of them will get relief. And about 20% of the patients get 100% relief at 6 months. So that's a home run. Again, that's very remarkable. The shoulder pain, this lady that we talked about, the good thing is we can use it for frozen shoulder. We hit a nerve that covers a lot of pathology, so you don't need a perfect diagnosis here. It's pretty broad. And for the hip, you see average pain score goes from 7 down to a 2. Nearly 100% of patients decrease their pain medications. You're sleeping better, you're walking better, your activities of daily living much better. The last case here. So this is a retired, this guy I saw on See Me as well. He's on the schedule for next Friday. 63-year-old gentleman, former policeman, 3 lower back surgeries. Presents with lower back pain. Majority of pain though is in his bilateral legs and not in his back. And he's frustrated. He wants to go lift weights. He wants to live in Florida, but he can't because he's in so much pain. His EMG showed a chronic L5 nerve injury, and the spine surgeon said, look, you are not a candidate again for a 4th surgery. The hardware was seated well as confirmed on CT. He was given tramadol, oxycodone, Percocet, didn't like the way it made him feel. He had friends that took too much as well. Which jumps out to me, lots of back surgeries. That's a big red flag there, that maybe we can help this guy. Lots of back surgeries, leg pain, not back pain, doesn't want surgery, and the meds do not sit well with him. So spinal cord stimulator, what's the concept behind a spinal cord stimulator? I say rubbing of the toe. So basically, I'll explain that in a second. The biggest thing I tell people is you can try it before you buy it. I don't know many modalities where we leave it in for a week, see how your life is. We take it out after 7 days. If you like the way it made you feel, we can put it in permanently. If you didn't, at least you tried. Let's talk more about rubbing the toe in a second, but these are the ways you got to identify patients. Do they have diabetes? This guy didn't have diabetes, but do they have diabetes and burning leg pain? Have you had back surgery? Remember, this guy had 3. Have you ever been told you had RDS or RSD or complex regional pain syndrome? Remember my father in the picture of France, complex regional pain syndrome. He would be a terrific candidate for this. Even lower extremities, but upper extremities, burning and tingling in the arms. What's the deal behind a stub toe? So when I say spinal cord stimulator, everyone says, look, I don't know what you're talking about. I said, okay, look at it this way. When you were a kid and you stubbed your toe, what did you do? Everyone did it. We rubbed the toe. And everyone said, yeah, of course. I said, do you know why that works? And this is built upon a 1960 seminal paper. Basically, when you stub your toe, that pain signal goes to your brain. However, if you rub your toe, now that rubbing sensation is faster than the pain signal. The rubbing sensation goes to the brain and gets in first. The pain signal can't get in. That's essentially an oversimplification of what's going on. So people understand this concept, right? So once you tell them that, they kind of get it. Once again, this is showing why the rubbing, the spinal cord stimulator, makes it feel less painful. Pain speed extremely slow, leisurely walk on the beach. The rubbing speed is very fast. I'm not a car person, but whatever car that is looks pretty fast to me. That'll beat out the pain speed. And what's the idea behind it? So it's like a pacemaker. So it's a little device that looks like a matchbox, can be put under the skin. The whole thing is basically, it's changed via your iPad or an electronic device. That's where the majority and advancements of this technology has come from. This came from the 1970s, but where we're at today, light years ahead of where we were. Draw your attention, look how small those wires are. Everyone's afraid that, oh, this is a permanent thing. It's super thin and flimsy. You can see how big it is. It is very small. It can be removed. It's not permanent either. Does this work? This is why I'm excited to be part of the CIN and bring this here. This is April 2021, so not that long ago. JAMA Neurology focused in on how do we treat diabetic neuropathy. So we're still talking about spinal cord stimulator. An indication for it is diabetic neuropathy. 3 medications are first line: gabapentin, Lyrica, and Cymbalta. Those are the top agents. Well, what's the problem with them? Remember, I'm a pharmacist. I was with the FDA. I practiced during the peak of the opioid crisis. I know when medications work. I like to think I know when they don't work. 60% of patients at 6 months with gabapentin and Lyrica stopped taking them. And the thing is, they didn't switch to something else. So they just stopped. They're still in pain. They still have diabetes. They still have burning pain in their legs. 60% of patients just stop those medications. And that's what we have as first line, best available. In order to see relief, you need to give the medication to 6 or 7 patients. Remember I told you with the burning of the knee, you only needed to treat 2 patients. Here, you got to treat 6 or 7 patients, so not the best odds. So I put in there, like, do you feel lucky? How does it compare taking the medications for diabetic neuropathy versus spinal cord stimulator? So compare and contrast on the left-hand side, starting scores about 7 out of 10. When they were taking medication, went down to a 6.9. That's not life-changing. That's not a home run. How about the spinal cord stimulator? Starting pain 7.6, went all the way down to a 1.7. That's a home run. We're talking about complete life-changing therapies here. Okay, how about what percentage of patients have 50% pain relief? With medications, 5% of patients had 50% relief. With the spinal cord stimulator, 79%. Please.
Doctor, is it the same dosage of medications with all by themselves and then with the addition of the spinal cord stimulator, or is it a decreased dosage they can tolerate?
They kept them on the same.
They kept them on the same.
Yeah, they kept them on the same. It's a good question. Are people satisfied with this? At 6 months, 92% of patients were satisfied or very satisfied as well. And this is the biggest thing. So this is really hard for me. So there was a lady I saw in clinic on Tuesday, and she's had pain for 7 years. People said they couldn't do anything for her. We did the trial, so the test, the first step where you get to try it out for a week. And she came in, and I walked in the room, her husband was there, and she's crying, and I was like, oh, I'm thinking to myself, it didn't work. That stinks. And she said, doctor, I haven't been out of pain for 7 years, and everyone tells me a variation of this. Why didn't somebody tell me sooner? And she's crying because she's like, do you know how many birthdays I missed? The times that we couldn't went camping. Do you know my husband has a Harley that we couldn't ride? She told me all the life events she missed out on. And she's like, why the heck didn't anyone tell me? And I get that multiple times. And I said, I'm not going to use your name, but I said, look, that's in the past. More people will learn about this therapy. And a lot of them say, I'm going to tell my friends. And that's really great. So just to review the big 4, the first one was ablation of the nerve in the vertebrae. That's the bone burner. Bone is home. Remember that guy, that young guy, pain right in the middle of the back. MRI was normal. Second one is this interspinous spacer. That's the shopping cart. That's when you go to Costco or Target, the person is leaning over. That's the older patients usually. Usually they're on the medically complex side of things. Third one is burning the hips, the shoulders, and the knees. That's the cookout, the patient who doesn't want surgery, again, or who has had surgery and still in some pain. And finally, that spinal cord stimulator, that one's the stub toe, the diabetic neuropathy, the multiple back surgeries like the guy that I saw down the road here. So switching gears now, so we talked about the big 4 advancements in pain. Now we're going to talk about, how to approach chronic pain in the primary care setting. And I fully admit my wife is a family medicine physician, that my life is a lot easier. I get the luxury of focusing on one body part, one complaint, and you guys have to juggle a million things. So this is my attempt to make your life easier. All right, a lot going on in this slide, but these are the recommendations and general tips. If you have a patient with chronic pain and depression, kill 2 birds with 1 stone. So if there's no contraindications, I'd recommend Cymbalta, 20 or 30 milligrams once a day. That is a lower dose, so there's less side effects there. You will help the depression, you will help the pain as well. I had a lady in see me as well, chronic knee pain. She didn't get any interventions. The surgeon said, everything looks great, bye. I saw her and I said, hey, what's going on? You look kind of down. And she explained that, her husband recently passed. She actually worked here. And she just feels isolated. And I said, let's try this Cymbalta, because Cymbalta will treat chronic pain and depression. She comes back and she's, on cloud 9. She's doing much better. She's more physically active. Next one in the primary care setting, set clear expectations. This is also a lady I saw down the road. I asked her, hey, when did your pain start? She said, 1977. There is no magic needle that's going to take away pain that she's had for that long. So I said, look, it's kind of like an onion. We're peeling back layers here. You got to work with me. You've had it for this long. We're going to be together slowly here, make you feel better. Next, this one always raises eyebrows. This is the one that people kind of challenge me and afterwards. They're like, really? Ask them, do you want to come down on your narcotics? There was a study that Beth Darnell from Stanford up north had shown that basically up to 40% of patients are willing to come down on their opioids. Maybe someone never asked them. Next, focus on functionality. People in the rehab space, physical therapists, get this as well. Sure, we have to ask what's your pain score, but really what I'm asking is what can you do? What can you no longer do? If your pain score is going up and you're gardening more, playing pickleball more, that's a win in my book. That's fine. Next, explain narcotics cause more pain than they take away, right? And the story I like to tell is I was at the VA doing an epidural for a gentleman, tough guy, and we started the epidural and he about jumped off the table. And the nurses looked at me like, what, are you using a new needle? I said, sir, what are you taking? Remind me again for your opioids. He's been on such a high dose of opioids for such a long time, he's causing more pain than he's actually taking it away. And that's terrible. And I'll explain to patients, like, you don't want those side effects. Your skin is terrible, you have no sex drive, testosterone goes down, you're fatigued all day, and you have more pain. Like, who would sign up for that? Next, I get it. In theory, no one should be on opioids. Practical matter, people are on opioids. If you're going to start something, I'd recommend Tramadol. If you're going to add anything else, the multimodal bit, think about Mobic, think about Celebrex, think about Voltaren gel. This is the concept of multimodal therapy. If you need a muscle relaxant, I really like tizanidine, Xanaflex. It's covered by Medicare. It works differently than your baclofen, your Flexeril, other muscle relaxants, Robaxin as well. And my personal recommendation, not from the CDC, but would be avoid codeine, Soma, in a lesser degree, Robaxin as well. Next, have knowledge of 3 pain management experts who specialize in medication management. They have the staff, they have the intake forms, they have the processes in place to help people who need medication management. Next, treat sleep as well. I'm really surprised. A lot of times, I saw this lady, she was inpatient. She got out of her surgery. I saw her at about 10 at night. She was in the hospital. This was day 2 or 3 for her. And I sat down with her. I talked to her for a while. And then I signed out in the morning, and the nurse is like, the nurse coming out said, what did you give her? Like, she's a lot better. I said, nothing. Like, I didn't change anything. I just added something to optimize her sleep. Sleep and pain, as we all know, is connected. Next, order PT and x-rays. If you want to expedite this workup, help us out. You don't need to do the full escalation of the workout, but a PT helps see where they're at functionally, how much they're willing to engage, what their limiting factors are, and then an x-ray as well. And if not, we can get them in office. Don't worry about ordering an MRI. It's totally fine. If you are writing opioids, these are recommendations from the CDC. Document the 5 A's. So are they getting pain improvement? We want to see 30%. Any behavior that's causing red flags to go up, missing work, jail time, DUIs. What's their activity level at? Is it going up or down? Any adverse effects, drowsiness, dizziness, fatigue. And what's their affect when they're coming in? Are they aggressive? Are they hostile? Are they yelling at your staff? Next, avoid the use of benzos. Really, this is the next big thing coming down the pipeline is a benzo epidemic in America. If you're gonna do an opioid, keep it really clean. Don't do an opioid and a benzodiazepine. Next, keep morphine milliequivalents less than 50 or 90. Just a word of caution. So this CDC recommendation, they're revising their opioid guidelines. I've been told, I can't speak off of any literature, I've been told and I've seen prelim reports that the next iteration will remove these numbers as well. So what is 50 morphine milliequivalents? What does that equal to? Put it in perspective. If you do Norco, 10 milligrams, 3 times a day, that's 30 morphine milliequivalents. If you do Tramadol, 100 milligrams, twice a day, that's 20 morphine milliequivalents. If you do Percocet, 10 twice a day, that's 30 morphine milliequivalents. So try to keep it under 50. Rarely do people need more than that, and that's where you can get some additional help. Next, if you are starting them on an opioid, see them in 4 weeks. And if you're chronically writing it for them, see them every 3 months. It goes without saying, check cures, just so you're staying in line with best practices. And this one, I get a lot of questions. Just because someone before you wrote opioids does not mean that you have to continue writing opioids. So once again, that was someone else's plan. You have your own volition to say, hey, is this the best plan or do we need to change it? So I'll end here, close to the hour here. So let's hit home runs. That's the name of the game. Pain management, we could do that and see me here. If you want any citations, we talked about the 4 different devices that